Right. Okay. So today we are going to cover the very basics um, of respiratory diseases. And before we go into diseases in respiratory system, I think we need to understand the basic groups, the two main groups of pulmonary diseases. And they are restrictive diseases, restrictive pulmonary diseases, and obstructive pulmonary diseases. Now, why is this very important? It's because the one of the highest mortality in hospitals, or just not just in hospitals, but in the healthcare industry, in the healthcare of the world, is because lung cancer is one of the things that's on top, and besides that, also COPD and asthma is also one of the bread and butter of medicine, and not just for us as medical personnel, but also for our patients as well. And one of the reasons why people with pulmonary diseases get admitted into the hospital is because of COPD exacerbation, not just COPD itself, but COPD exacerbation. And when COPD gets exacerbated, it's because of secondary infections, and that would require more than the typical treatment for COPD and asthma. So I've also decided that today it would be best to not cover COPD, as I mentioned in the group. We're going to cover mostly on pulmonary function tests, spirometry, and flow volume. And but I feel that if I want to cover COPD, I will be rushing, and I don't think it's fair for Josephine and Ufi to for me to be rushing to cover COPD. So I think it would be best for me to take my time, take our time to learn COPD and to go through COPD step by step again. Although COPD can be a little bit, familiar, or a lot familiar to a lot of us, because it's not the first time for all of us to encounter COPD, or to learn about COPD. We've learned COPD since third year, right? And as we progress, COPD gets repeated over and over again, not just in third year, but also in fourth year, also in fifth year, and stuff like that. Even in sixth year, when we learn about differential diagnosis of obstructive lung diseases, we still have to go through COPD, we still have to go through asthma, we still have to go through bronchiectasis and just bronchitis as well, both acute and chronic bronchitis. So again, it gets recycled over and over again. So it can get a little bit boring. Just bear with us for a bit. Hopefully there's something new that we can learn from, and not just the things that we think that we're familiar with. So yeah, before we go into before we go into that, also I think that what we're going to cover today is enough foundation for our next upcoming extra class that Ivy is going to conduct, that I gave Ivy to conduct our very first um, non-Norman person who's going to conduct the class. And she's going to cover bronchial asthma, which is one of the obstructive pulmonary diseases. And I think what we're going to cover today will be enough to sort of give us a foundation for as of the diagnostic methods of obstructive pulmonary diseases. And as we go through asthma, almost the same as what we're going to go through COPD. But then again, when it comes to the pathophysiology and treatment, a little bit different of COPD and asthma. Um, there'll be slight differences and all that. So yeah. Uh, so today, what we're going to cover today will be on pulmonary function test. And of course, this is not the exclusive test that we order for a patient that comes in that you suspect with restrictive pulmonary diseases or obstructive pulmonary diseases. Of course, there are other battery of tests that you want to perform, that you can perform, the basic routine blood tests and stuff like that. But I would like to just emphasize, I would just like to highlight pulmonary function tests, because they are not just the things that we are familiar with, or not just the routine things that we order. And I would just like to highlight this, and would like us to understand this, because not just because they are clinically significant, but because they are also tested in board exams as well. And these are the things that we need to understand when we do board exams, for example, USMLE, PLAB, or any board exams in our respective countries as well. All right. So why do we need to perform pulmonary function test? It's because we want to differentiate, like what I've mentioned earlier on. We would like to differentiate whether this particular patient is having an obstructive pulmonary disease or a restrictive pulmonary disease, right? And this distinction actually is very important, because it also dictates what type of treatment we want to give, and what type of other battery of tests that we want to perform as well. So we need to the important part, the emphasis of the significance, sorry, of PFT, pulmonary function test, is to categorize the type of lung process, whether it's restrictive or obstructive. Second is the second reason why we want to perform PFT is because we want to assess severity of the patient. And why we would like to understand severity of the patient. Again, it also dictates not just the treatment of for the patient, but also the prognosis, and also any operative procedures that we want to perform. For example, in tuberculosis, patient with tuberculosis, that we want to perform lung resection. Basically any operation on the lungs, we have to perform PFT. Mandatory PFT needs to be performed. That is why um, this is important. Again, for example, in COPD, if you remember, when we went through COPD, for some of us, that we went through COPD the last time, we talked about how we need to stratify the patient into goal 1, goal 2, goal 3, and goal 4. And all of this goal 1, goal 1, goal 2, goal 3, and goal 4 is based on your spirometry value, specifically your FEV over FVC ratio. We'll talk about what FEV1 to FVC ratio is, or in other words, the TIFNO index, a little bit later on. So just want to paint a picture that this is important, because you want to assess severity. Also, for example, in asthma, we need to also know the severity of the patient as well, whether it's moderate persistent, whether it's um, mild, whether it's mild or persistent. And to again, we need to stratify patients when it comes to uh, patients with asthma. This I think Ivy will cover in our next extra class. There's a table that stratifies asthmatic patients, and from there we can decide which step that we want to start treatment with, whether it's step 1, step 2, step 3, up to step 5. So here comes again, here is where the PFT plays into the picture. Next reason why PFT is important is because we want to evaluate the treatment, the effectiveness of the treatment that we want to give. For example, bronchodilative treatment with bronchodilators, or treatment with let's say well, basically most of the time um, treatment with bronchodilators, not just your beta 2 agonist, but also your, for example, your terbutaline, your well, basically other we'll talk about different types of bronchodilators when we talk about COPD. So yeah, effectiveness of the drugs that we prescribe, to understand whether they are effective or not, or if the patient is refractory to such treatment, PFT can help us with that. Okay, so what are the groups of PFT that is performed? By the way, the very normal, typical, the easiest PFT that we can perform, of course, is spirometry. It can be performed in any office setting. But if you would like to perform any other test of that falls under PFT, we probably would need the patient to go to a pulmonary lab. And I understand that not all hospitals have pulmonary lab, but if you are lucky enough to be in a hospital, or to be privileged enough to be in a hospital with a pulmonary lab, you'll be able to perform other battery of tests, battery of PFTs for the patient. Okay, so what other groups of PFT that we can perform for the patient? Number one, if you, of course, I would like everybody to jot this down. The first one is called static lung compartment. Static lung compartment, and this refers to your spirometry. This measures your total lung capacity, your vital capacity, your residual volume. Basically, again, your spirometry. The first one is called static lung compartments. Second is airflow or movement of air. Airflow or movement of air. This is your FEV, forced expiratory volume, FEV1, or your FVC, forced vital capacity, or something called FEF 25 to 75. What does that stand for? Forced expiratory flow 25% to 75%. We'll talk about what that is a little bit later on. Again, second group is airflow or air movement, and that is your FEV, FEV1, forced expiratory volume, your FVC, forced vital capacity, or FEF, forced expiratory flow, 25 to 75%. The next group of PFT that you can perform is something called alveolar membrane test. Alveolar membrane test. Specifically, your diffuse capacity test, or something called DLCO test. You don't have to, you can just write this down first. We'll talk about this again a little bit later on. Next, the fourth test that falls under PFT is something called methacholine challenge test. Methacholine challenge test. The fifth one is bronchodilator reversibility. Bronchodilator reversibility. By the way, the very first time I gave this class, I did not cover quite a number of this. And you guys are in luck because I decided to cover this today, just to, fill up the time for our class. Because previously we had our class for 3 hours long, so we kind of have, extra time to talk about COPD and stuff like that. But well, now that we are only specifically talking about PFT, I decided to add more things. Hopefully, we'll be able to cover everything in time. All right. So let's first talk about spirometry. Spirometry. Of course, when we talk about spirometry, we are all already familiar with the graph. Of course, maybe some of us are not familiar, but we all know that there is somewhat a graph involved. Okay, I hope everybody can see the graph. Yeah? All right. Okay, now this is the very, very basic graph that is that we might see or we might encounter when it comes to spirometry. Again, if you see on the y-axis over here, let me annotate. This y-axis over here, it says that you see the maximum is 6. Is it necessary for us to understand to limit the patient's lung capacity to 6 liters? No, because different people that have different lung capacity. Some people have 4 to 5 liters, some people have 5 to 6, some people have even 7 to 8. For example, athletes and stuff like that. So development of the chest is very imperative when it comes to volume of the lungs. That is why to over to generalize the population, saying that the average lung volume for people is about six liter is a bit risky. So therefore, it is just not advisable to just assume that everybody's lung capacity is 6 to 7. Of course, we need to see the patient and ourselves and to decide that. Okay, so we are first going to cover the very first group of PFD, and that is your static lung compartment. And you see here, although there's just so many things on this graph right here, I'll show you some more things later, a little bit later on, just to scare you. Um, because when it comes to spirometry, there's just a lot of things, that a lot of parameters and that comes into the picture. A lot of parameters, sorry, a lot of parameters, you can call them parameters. A lot of parameters that come into the picture, but there are only a few parameters that are clinically significant. I'll point them out. Although it's good to remember the rest, of course, as we specialize, if you want to specialize into internal medicine, or you want to be a pulmonologist and stuff like that, of course it'd be good. Of course, I think it's necessary even for a specialist to know all the extra parameters. But what are the parameters that are clinically significant? First one that is clinically significant is your tidal volume. Why is my pen very weird? Okay. The first parameter is your tidal volume. Your tidal volume, what is tidal volume over here? Tidal volume simply means that if you are the person who's going through spirometry, who is under spirometry, tidal volume simply refers to your normal breathing. Just the maximum and minimum, just the maximum expiration and minimum expiration during a very normal respiration. Not force, not strain or whatnot. The patient is not trying to inhale or exhale as much as they can. Just normal breathing. So you see here, what goes up is your inspiration, goes down in expiration, inspire, expire. So this is your normal tidal volume. The next parameter that is clinically significant is your, let's see, which one do I want to choose? Let's do vital capacity. Okay, this is the next one that is clinically significant. What is vital capacity? Vital capacity basically is the amount of air the patient can maximally inhale and maximally exhale. Maximally inhale and maximally exhale. See this one over here. See the up from here to here. So you tell the patient to inhale as much as he or she can and ask the patient to exhale as much as he or she can. Okay? Next significant parameter is residual volume. What is residual volume? Residual volume is the amount of air that the lungs have even after maximum expiration. You expire, you can't get rid of any air anymore. You think you don't have air anymore in your lungs? You're wrong. There's still air in the lungs. And that amount of air that is left in the lung is called residual volume. Why is this important? It's because your alveoli will have to be supported. And in order for them to be supported, it requires air. If it's not supported, it will collapse, and you don't want your alveoli to collapse. Therefore, that is why the air is left there, and it's called residual volume. The next clinically significant um, parameter is your total lung capacity. What is total lung capacity? It is it is the maximum amount of air that the patient has, including your residual volume. Everything. So basically, to get your total lung capacity, just ask your patient to inhale as much as he or she can until that patient cannot inhale anymore, if sure. That is your total lung capacity. You already know that it already includes your residual volume. Is it important to memorize the rest? Okay, if you want, if you can if you want. But these are the four clinically significant ones. Why are they significant? I'll explain them a little bit later on. It's because they will give you a picture whether it is an obstructive lung disease or it is a restrictive lung disease. Okay, next thing that I would like to show is to scare you. Okay, these are some of the parameters that is also included in your spirometry. I took this. This is MRCP material. It is the board exam for specialization in internal medicine. So see over here, these are just some of the things that's also in spirometry and what it is. You think it's only one page? Ta-da! There's the second page. You see some more. The normal expected value, how to calculate it, and you see all of this, including your anatomical dead space, your physiological dead space. I think that's pretty interesting if you're interested to learn that. And yeah, okay. Although you see here, it says that in male normal is 4.5 ml, in 4.5 liters, and in female 3.5. But this really varies really according to regions. I guess this one is mostly for UK people, I guess, but different countries have different parameters. Anyway, clear so far what these things are. These four parameters are. Any questions before we move on? No? Alright, sure. Alright, so static lung compartments is now we've covered the four ones. Let's now move on to uh one second. Okay, before we move on, I want just to do a little math. So you see here total lung capacity, right? If you want to find vital capacity, it means you can find it by subtracting total lung capacity with your residual volume, right? So right. So from this graph, you kind of can maneuver around and find out how to get the values if you don't know how to get the values. Sometimes you don't remember the formula and stuff like that. Just remember this graph. You'll know how to calculate it just from the graph. Okay, next is your airflow movement. Airflow movement, or yeah, airflow, and that is your FEV and FVC and FEF 25 to 75%. Okay. Now, what is FEV or FVC or FEF? So you see from the term, it's a forced expiratory volume. Now, a very common misconception is that when somebody or anybody who's learning medicine is when they hear force, it means something that is a certain amount of exertion that is placed on that patient uh, for something to be measured, right? But in this case, technically, it's not entirely wrong. But when somebody refers when when it comes to spirometry, when we refer FEV, we are not referring to the ability of the lung to take something in when the patient is forcefully inhaling or forcefully exhaling. No, what we're measuring here is speed. From the name itself, airflow or air movement. What we're measuring here is speed. What is force here? Sorry, 1 second. Somebody's calling me. Okay. Um, where was I? Right. When we talk about force volume, we are referring to the speed of the airflow. So we tell the patient to to exhale as fast as he or she can. That is the force part that we are referring here. We're not referring to the restraint that we demand of the patient to inhale or exhale. Of course, we would like the patient to inhale as much as he or she can, and then exhale as fast as he or she can. That is what we want. We would typically would ask, but what we are measuring is the speed of the air that flows through the spirometer, right? Not just through the of course through the respiratory tract, but we're blowing, essentially blowing into the tube, right? Okay, so right here we see um that the FEV, what is FEV? Forced expiratory volume. So we ask the patient to inhale as much as he or she can, and then we ask that patient to, oh, I don't want blue. Let's do green. Okay. So we ask the patient to inhale as much as he or she can, and then we ask the patient to exhale as fast as possible. So we are measuring the speed of the airflow every second. Therefore, there is a term of FEV0, FEV1, FEV2, FEV3, 4, 5, up until it reaches residual volume. Or in other words, until the patient cannot exhale anymore. In other words, we are measuring not just FEV, but we are also measuring your total lung capacity. Your total lung capacity or total vital capacity, not vital capacity, total lung capacity, yeah, basically. But here we are calling it force vital capacity, FVC. Understand so far? Yeah? Okay. Now, now that we understand what FEV1 and FEVC is, it is also important, it is also important for us to find out the ratio between FEV1 and FVC. This ratio is typically called TIFNO index. If you might have heard this before, if you go through propagetics material or maybe some therapy material here in KSMU, they call it they spell it TIFNO. But when I continue to read and stuff like that, they don't spell it. The actual spelling is not TIFNO. It's TIFFANEAO. TIFNO. I think the name is French and stuff like that, just for, I guess, for convenience sake, or yeah, maybe they just don't know how to spell. So they just call it TIFNO, TIFNO. So your TIFNO index, or in the US, they don't call it TIFNO index, they just call it FEV1 over FVC ratio. Now, Why is this important? The ratio will tell us whether it is a restrictive or obstructive lung disease. If your ratio is less than 80%, some resources might say 70%, but typically most of them they say 80%. So if it's less than 80%, that is an obstructive lung disease. Less than 80%. Normal, of course, will be more than 80%, but more is as in 80 to 100. Okay? If it's more than 100, that is also a problem. That is also a problem. That indicates air trapping somewhere. But anyway, we're not gonna, I don't know if we have time to talk about that, but essentially less than 80%, um, it, it would indicate obstructive diseases. However, however, this, especially in the case of asthma, although we all know that asthmatic patient, asthma basically is an obstructive lung disease, but the thing about asthma is that it only manifests itself during an attack, right? You don't see asthmatic patient wheezing every time. They can sometimes even uh, they just do their daily activities normally to without having difficulty. And only when there's a trigger, for example, cat fur or dust and stuff like that, or just anxiety and stuff like that, whatever that triggers the asthma, only then the patient will start wheezing. So therefore, in asthmatic patient, your teeth no index can be normal. That is why to generalize and to say that when your FEV1 to FVC ratio is less than 80% and it is exclusively for obstructive lung disease, it is not entirely accurate, because in asthma patient it can be normal because of what I mentioned earlier on. All right. This is your FEV1 to FVC. Now there's another test called FEF, forced expiratory flow, 25% to 75%. I'm not gonna explain so much about it because it's not really that important. Also, we are not really the person who's in the lab who's going to do all these things. Also, the result of your FEF 25 to 75 will also be reflective of your FEV1 to FVC ratio, your teeth node index. It's also the same. The whatever it is that you measure, the conclusion is still the same. So basically, how you do, just you can just listen to this. You don't have to. If you would like to point it out, you would like to write this down, you can. But if you would like to know, basically you just draw a graph again, just like your the graph that I showed you earlier on. But it's more of after that you kind of have to draw a tangent. I don't know if you remember calculus, when there is a curve somewhere, you want to find the slope in that curve, right? That particular slope. And to find slope, um, also to find what how much the rate is, right? You need to perform a differentiation, right? Calculus basically. And to differentiate that, of course, you don't do the differentiation, the computer will do the differentiation for you. But essentially the principle is to perform differentiation and to find the slope and to kind of get some value, and that value is indicative of whether it's obstructive or restrictive lung disease. um Although I mentioned earlier on that it's not that really important for us to know, but I think it's also the only thing that I would like us to remember is your FEF 25 to 75% is more indicative. The indication that it is an obstructive lung disease is more, I wouldn't say accurate, but it's faster in comparison to your spirometer. So that's just a distinction of if you send a patient to a pulmonary lab and the patient undergoes FEF 25 to 75, it is faster. If you see that it indicates obstructive pulmonary disease, um, and if you don't have time, it's already enough. If you have time, of course, your spirometry will reveal almost it will reveal the same result. Okay, before we
Please,
move
I have a
on,
question, please,
yeah,
before we move on. My internet had problem. Please, how do we know if it is obstructive or restrictive? This post expiratory flow.
how to know if it's obstructive or
Like how
restrictive?
do yeah with
Mm-hmm.
post expiratory flow.
Okay, yeah.
25 to 75%.
I'll explain it a little bit now. Now actually,
Okay.
I'll show everybody a table. 1 second, let me show you the table. What? Okay. Earlier on, I said that your FVC, FE1, your teeth node index is reflective of obstructive versus restrictive. But there are other parameters. When I mentioned earlier, or remember when I mentioned all the four clinically significant parameters in your spirometer, it helps as well to distinguish what is obstructive and restrictive. Okay, so let's go through one by one. Oh, what do I notate? Okay, let's start with FVC. Basically, okay, let's not start with FVC. Now, earlier on, I mentioned that if your FEV1 to FVC ratio decreases, that is already obstruction, right? Okay. Um, but essentially, your obstructive lung diseases, patient with obstructive, the difference between obstructive and restrictive lung diseases is that patients with obstructive lung diseases, the problem that they have, of course, the complaints that they have is shortness of breath, right? Dyspnea or SOB, shortness of breath. But the thing is that when we understand, when we talk about dyspnea, there are two types of dyspnea, correct? There's expiratory dyspnea and there's also inspiratory dyspnea, correct? If we would like to find out really which type of dyspnea falls under obstructive lung disease, what falls under obstruction and what falls under restriction. Technically speaking, in obstructive lung diseases, it's both expiratory and inspiratory dyspnea, but it's more towards expiratory dyspnea because the patient has difficulty filling their lungs and also has difficulty has the patient has difficulty to empty their lungs and also difficulty to empty their lungs fast enough. These two things um, are the two problems in your obstructive lung diseases. These two things cannot empty the lungs, number one, and cannot empty their lungs fast enough. So understanding cannot that the patient cannot empty their lungs fast enough, it means that your FEV1 will decrease definitely, right? FEV1 will decrease. But your forced vital capacity might be normal or even possible to decrease. But because the problem is not that the lungs cannot take in air. The lungs can take in air. The lung parenchyma is technically quite normal. But the problem is the respiratory tract itself, the alveolus, wherever it is, whether it's from the bronchus up till the alveolus. But the lung parenchyma itself is essentially normal. So that is why your forced vital capacity or your total lung capacity in your spirometry can be normal. But the thing is that your FEV1 will decrease, definitely decrease, because now that the patient cannot empty their lungs fast enough. So when we perform ratio, your numerator is your FEV1, right? and your denominator is your FVC. So if we do just simple math, when your numerator decreases, the decimal will also the ratio, the decimal points or the ratio will definitely decrease as well. So, but if your, let's say your FEV1 is normal, but your FVC decreases, that means that your TIFNO index will increase, which we're going to talk about a bit later on in restrictive diseases. But let's just talk about obstructive diseases first. So now that we've covered FEV1 and FVC, so technically, um, your FEF 25 to 75 will also decrease. As I mentioned earlier on, it is reflective the same. It reflects the same conclusion as your TIFNO index. All right. Now, what are what are other distinctions in obstructive lung diseases? It's this one. You see, this increases. What is this? Your forced residual capacity, your residual volume, and your total lung capacity will increase. Why? Why will this increase? Because because when the air goes into the lungs, like I mentioned earlier on, it's difficult for the patient to empty their lungs, right? It means that there's some form of air trapping in the lungs. For example, in emphysema, COPD, right? That the patient has barrel chest on emphysematous chest. It's because the air cannot go out due to the permanent destruction of the alveolar walls. So that is why when you perform spirometry, the total lung capacity now increases because there is leftover air in the lungs. So there is your now that there's a lot of leftover, your residual volume increases, and also your forced residual capacity increases too, and ergo, of course, your total lung capacity. Okay, so when you see all these three parameters increase, TIFNO index drops, your FEF 2575 decreases, sure, obstructive lung diseases. However, in restrictive lung diseases, because the problem now is in the lung parenchyma, the problem is not on the respiratory tract. The patient can breathe in and out basically normal. The patency of the respiratory tract is intact. And now the patient cannot breathe, cannot take in enough air. The problem is in the lung parenchyma. For example, in this room right here, maybe we can this room that I'm in can accommodate up to 50 people, for example. Now that number is already limited. If you have 100 people, it means that you cannot fit into this room anymore, because the problem is not because the door is not big enough, or the door cannot accommodate enough people to go in and out, but just simply because the room is not big enough to accommodate 100 people. So that is why your FEV1 can be normal in your restrictive lung disease, can be normal, but your vital capacity can decrease. Your vital capacity can decrease simply because the lung parenchyma is affected. Remember, your vital capacity is your maximum inspiration to your minimum inspiration, right? This does not include your residual volume. So that is why that can decrease. So what happens to TIFNO index? If your FEV1 is normal, it means your numerator is normal, but your denominator is the one that's decreasing. It means when you perform ratio, the number becomes bigger and bigger. That is why in restrictive heart diseases, your TIFNO index can be more than normal, simply because your FVC decreases and your FEV1 is normal, or maybe increase. but it might even be reflective of normal TIFNO index, normal to elevated, of course. If it gets a bit severe, probably elevated. But in the range of TIFNO index can be in the range of normal. And like I mentioned earlier on, your TIFNO index is also reflective of your FEF 2575. That is why your FEF 2575 can also reveal normal as well. But the problem here is here again, your residual volume. Because the lung parenchyma is now no longer be able to hold that much air, your residual volume can decrease. Thus, your total lung capacity as well. Okay, so this is how to differentiate obstructive and restrictive lung diseases based on spirometry, both your static lung compartments and your airflow and movement parameters. Clear?
Mm,
Question?
Number.
Hmm?
What's the difference between force residual capacity and residual volume?
What is the difference between?
Force residual capacity and residual volume.
Our force residual capacity is when we perform airflow and movement test. But residual is when we perform static lung compartment. Technically, they are almost the same. Basically, they are the same. Just that when you do it is different. The purpose is different. Okay, clear? Josephine, did it answer your question?
Yes, thank you.
Okay, cool. Now, before we move on, I would like us to do a little bit of exercise. Okay, I'll give you a few numbers and you tell me if this patient is having obstructive lung disease or restrictive lung disease. Okay, ready? All right. um, Total lung capacity is 7.4 liters. Total lung capacity, 7.4. Residual volume, 1.2 liters. Forced expiratory volume, FEV1, is 5.1 liter. What is this patient having? Obstructive or restrictive lung disease? Let's give it 5 minutes and you tell me.